disease, in that he had previously had a cabbage and a stent, in that he also had high blood pressure. And for this, someone's audio is not muted. For this particular case, I believe it was in the early morning that I believe it was like 5 o'clock in the morning, but he woke up with these symptoms. He got up and he felt like he was going to pass out. He had some transient chest pain, for which he took his home nitroglycerin and sat back down. Yeah, it's 5:30 in the morning. So initial 12 lead was obtained within 1 minute, repeated again at 2 minutes, and then here are his 12 leads. For the most part, they are consistent, so I did put both of them up here. Looking at this, you can see that the life pack had made many interpretations on what the rhythm was obstructing the view of V1 in both 12 leads and partially obstructing the view of V4. EMS had interpreted this EKG as a SVT. An IV was placed, and he was given 6 milligrams of adenosine at 5 minutes. Repeat vital signs largely were the first ones obtained. So after his 6 milligrams of adenosine, they continued with 12 milligrams of adenosine, no significant change. They placed him on nasal cannula oxygen at 6 liters for his borderline hypoxia. And at 12 minutes, since there wasn't any significant change besides he stayed in his SVT. It slowed down a little bit with adenosine, and then he had a change in rhythm that looked like VTAC. They shocked him at 100 joules. He stayed in VTAC. They shocked him again at 200 joules, and they interpreted his rhythm as VTAC. And I'm going to show these images of the 100 joules and 200 joules. And at that decision, or after shocking him, they made the decision to give him 150 milligrams of amiodarone. He had, at 19 minutes, runs of VTAC, and at 20 minutes, he converted into sinus arrhythmia. At 28 minutes after patient contact, they initiated transport and activated him as a STEMI alert. Next set of vital signs at 32 minutes showed that his heart rate had decreased to 59 and that his blood pressure was 103/69. His respiratory rate increased a little bit from previous to 22, but his GCS maintained at 15. They repeated 12 leads at 34 minutes and 35 minutes. And another set of vital signs that show persistent, stable condition of this patient. And this is the 12 lead after he received amiodarone. A second IV was attempted at 42 minutes. He received full dose aspirin at 45 minutes, and then another set of vital signs were repeated, now with a blood pressure improvement to 121/68, and they arrived at the hospital at 50 minutes. I don't know if we can make this any bit interactive. Anyone have any thoughts, concerns, things that you would do differently? You know, Monday morning quarterbacking. Maybe not a lot of people want to talk about it. Oh, go ahead.
I have some thoughts, but I'll wait till you're done.
Okay. All right. So after reviewing this case, what's that?
I would just, the chance of a 77-year-old with coronary artery disease having SVT rather than VTAC is very, very low.
Those are good points, Dr. Mock, and I'm sure Dr. Whitwer would have something as well regarding that.
Actually, I'll chime in now because we're going to chime in. I agree entirely with that. And even if this was a younger person, and possibly, I don't see anything on this 12 lead that makes me think that this is an SVT. But if you refer to our orders very specifically, and I know that V1 is hidden, but we have a wide complex tachycardia, and in V1 we have definite downward deflection. So this is a wide complex tachycardia. And whether it's and if you consider if we say, oh, well, maybe this is supraventricular, even if it isn't, your orders are specific that amiodarone and calcium channel blockers are not to be used in wide complex supraventricular tachycardias. Because you'll block the SA node and you'll have no other way for the supraventricular beat to get into the, you block the AV node and you'll have no other way to get the supraventricular beat into the ventricle through that AV node for 20 to 40 minutes, and you're into persisting VTAC, which is possibly why the VTAC continued when they tried to shock it, because there's no way the effect of the adenosine will last for a few minutes at least, and so it's probably going to make it difficult to get back in. The treatment of choice would have been amiodarone if you're going to treat it with a drug.
Thank you. That is, you cover a couple of things I have in the future slides. So I think that reviewing this crew recognized this patient was sick. They got an early 12 lead within a minute. They were able to switch gears when they felt that the care that they went down was not helpful or not improving the patient's condition. They also obtained serial 12 leads in that although they had this patient improve during the course of his care, they went ahead and made sure to give the patient some aspirin, check a glucose, and considered a second IV. I thought that their documentation on their thought process was pretty complete. It was very transparent on what I was reading, what their interpretation and their thought process moving forward, and that they had pulled up additional Versed in the event that they had to shock him. And where I think we can improve, as mentioned by both of our docs on the call, is that the rhythm identification was probably interpreted as incorrect. It was likely VTAC, and I'm going to talk about that further after I give you a follow-up. So in the emergency room, although he was activated as a STEMI, and my understanding is that it has to be confirmed by the ER doctor, he was downgraded upon arrival, and he was admitted for serial troponins and cardiology recommendations. On hospital day 3, during his admission, he underwent a left heart cath that showed patent grafts, and no stent was placed from this cath. He did have evidence of severe native vessel disease in that a dual chamber cardiac defibrillator was placed on hospital day 4 with his discharge the following day. So there's one of the things that we talk about when we learn about rhythm identification is that you can be fooled potentially with a SVT with aberrancy, and reason why it's important to recognize that all things wide are not always a condition of ventricular tachycardia, is that you want to, do the right thing, as Dr. Whitwer just mentioned about why giving amiodarone to an SVT with aberrancy, or shocking somebody that isn't appropriately shocked, or giving adenosine to the wrong rhythm could be detrimental. In that, that's what my second bullet point tells you, is that AV nodal blocking agents can be harmful when given in the wrong context. So I thought it might be a good idea to talk about why, one of the things that Dr. Mock had said, given his age and his cardiac history, it puts him at an increased risk for actually having ventricular tachycardia. But here's a couple of points that might be helpful in these situations when you're not sure. So extreme axis deviation, so down in lead 1 and down in AVF, would build your case for VTAC. Very broad complexes greater than 160 milliseconds would build your case. AV dissociation, where the P and QRSs are at different rates throughout the rhythm, builds your case. Fusion beats, if identified, will help you in persuading yourself in recognizing and treating VTAC. Capture beats, where the SA node transiently captures the ventricles in the midst of AV dissociation, also speaks towards VTAC. And then overall positive or negative concordance throughout your 12 lead would suggest that this would be possibly VTAC. When the beginning of the QRS to the lowest or the most negative portion of the S wave is greater than 100 milliseconds, it's called Brugada sign. That builds your case for VTAC. If you identify Josephson sign or notching or slurring of the S wave, that also speaks towards VTAC. And then if you have an RSR prime where the left ear of the rabbit ear is taller than the right, it builds your case for VTAC. And if your QRS is wide, but you lack the typical morphology of left or right bundle branch block, builds your case for VTAC. So in this particular patient's 12 lead EKG, using these points in addition to the fact an advanced age or an elderly person with a history of cardiac disease also builds your case for VTAC. But in this patient, he had positive concordance, he had Brugada sign, he had Josephson sign, and he had the absence of a typical right or left bundle branch. And then additionally, as Dr. Whitwer mentions about lead V1, although partially obscured. And then as for our Clark County protocols, unstable tachycardia is differentiated from stable tachycardia, but in this regards, this patient's blood pressure was 100 by palp. He had signs of evidence of poor perfusion with his pale, cool, and diaphoretic skin. You could convince, or you could build your case or persuade someone that you recognized him as being unstable, and unstable would be the consideration to cardiovertum or not cardiovertum, with the first line being amiodarone 150 milligrams for non-cardioversion. And then if you do cardiovert, would be synchronized cardioversion, which this crew did do synchronized cardiovert, although Versed was not administered. All right. Does anybody else have anything else to add about case one? Then moving forward.
I agree. Yeah. I agree with all your comments, and I just try to keep things simple for myself. Like walking in to see someone who has a bad heart, so elderly coronary artery disease, you really have to prove to yourself that it's not VTAC, and it is. I mean, the chance of something like this having an initial presentation of SVT is just very, very low. So just that, in addition to all the things you said, which are correct, the odds are just super, super low of this person having SVT.
Agree. You have to, if it looks like a duck and walks like a duck and quacks like a duck, it's got to be a duck. The chance, and he's had no history of previous SVTs either. So with that long cardiac history, and so it's always simplest in the middle of the night when things are scary to just do the simplest thing. Pick the worst problem that can happen with that wide complex tachycardia, and it's VTAC until you're done.
And if the decision tree was made that this was unstable tachycardia, it would be to cardiovert regardless. So
yeah, and and probably and my contention is that likely the cardioversion would have worked if he hadn't had the adenosine on board.
Mm-hmm. So, as we all know, the patients tell us less what's actually going on, but this patient had all kinds of risk factors: hypertension, smoker, diabetes, in addition to and high cholesterol, in addition to the two that he mentioned, which was just the coronary artery disease and hypertension.
And I would not have sent the first 12 leads, the first two 12 leads to the ED as evidence of a STEMI. I would have waited until you've actually had conversion and use that just like we don't base in a out of hospital cardiac arrest, we don't usually base the definition, the diagnosis of STEMI on the 12 lead that's taken within 1 or 2 minutes after ROSC. You usually wait for about 10 minutes.
Yeah, that's actually a good point. I forgot to mention that. I did want to bring it up, is that, you know, when we see evidence of ischemia in patients' extremis conditions, we can see that their heart is impaired because of either the hypotension or the tachycardia, or maybe even the bradycardia, and that especially if that has been resolved and you no longer see ischemic changes, that should be the EKG that you are really focusing on the rest of your treatment. It's not necessarily incorrect to say, if you gave this a Pulsara report, as this patient had dizziness and chest pain, but he was also in a ventricular tachycardia that has been now chemically cardioverted. And then to get that EKG and tell them that you saw some ischemic changes, but in the setting of the stressor, I don't think that we should be moving forward with calling it a STEMI based off of resolution on subsequent EKGs.
Right. Concur.
Awesome. All right. So moving on, 49-year-old female, EMS was called on a sick abnormal breathing. PPE usage was appropriate for the condition. The patient was found to be awake. Her airway was open. She was protecting her airway in that she had a pulse. She was warm and clammy, but there was no evidence of active bleeding. She was found in bed, I believe, just lying on her side. Vital signs obtained were a heart rate of 49, a blood pressure of 159/80, respiratory rate of 38. GCS was normal, and her room air sat was 99%. The past medical history that she provided EMS was that she had a history of heart disease, heart failure, COPD, diabetes, high cholesterol, depression, and then in her med list it said that she was on warfarin, but there was no indication for why she was on warfarin, at least in the documentation. Sorry about that. And then she reported to EMS that she was feeling poor for approximately a week, that she was experiencing body aches and weakness for the last 3 days, that she reported nausea, vomiting, and diarrhea, and stated that she had at least 3 episodes of vomit, and that a month prior she was admitted and hospitalized for an MI. So first thing checked was blood glucose, which came back as high. Vital signs, as I previously mentioned in the slide, were obtained. A 12-lead EKG was obtained at 12 minutes and then repeated at 13 minutes, which is this one that you can see. I believe the interpretation was just bradycardia at a rate of 28 according to that 12-lead. Repeat set of vital signs, heart rate of 38, blood pressure 153/67, continues to be tachypneic at 30, and SpO2 is normal on room air. Transport was initiated at 22 minutes, another repeat vital signs, which is largely unchanged from previous. Her end-tidal CO2 is noted to be 25, and she was placed on 6 liters nasal cannula at that time, because she had reported that she felt short of breath when they moved her, and that after they placed her on oxygen, she felt better. Multiple attempts were made at IV access which wasn't successful until the 4th attempt. And another set of vital signs were obtained 7 minutes from the previous one, with a heart rate documented as 90 and blood pressure 137/93, again tachypneic at 40, and normal sats, mildly diminished GCS of 14. I think it was mostly out of drowsiness. And then end-tidal CO2 again is a little bit low at 24. At that point, the decision was made to give her 1 milligram of atropine as well as 8 milligrams of Zofran. with a repeat 12 lead within 3 minutes. Oops. Here, which was unchanged from the previous EKG. She arrived at the hospital at 35 minutes without any significant changes in the abnormal vital signs that she had previously displayed. In review of this case, serial 12 leads were obtained. They placed her on pacer pads. They checked her blood glucose, which read as high. They did get serial vital signs, and they also were thorough in getting an Untitled CO2. Where we can see improvement would be earlier IV access, then I think it was 20-some minutes, 28 minutes, 25 minutes, and looking at those 12 leads and trending them and stepping back and looking at your whole picture, where you've got a patient who reports nausea, vomiting, diarrhea, her blood glucose reads high, she's got a wide, slow rhythm, she has tachypnea and decreased Untitled CO2. So kind of looking at that big picture and trying to determine the most appropriate mode of treating this patient. So in the emergency room, we obtained a 12 lead, which I'll show you after, actually I'll show you now. So the 12 lead on the left-hand side was similar to what EMS had obtained. It was slow, it was wide. There was no discernible P waves that would make you think that she had any type of block. And then this is a case that I had. My concern was not only was there potentially an electrolyte problem related to this, but also the fact that maybe she's in renal failure and that maybe some of her home meds have been have accumulated at toxic levels. She was on a beta blocker, so that was one of the considerations. Given that we confirmed that her blood glucose read just high, we didn't have any vitals or any labs back at that point, but given that she was undifferentiated bradycardia, wide complex, she was given calcium chloride 1 gram, and she responded to that 1 gram of calcium chloride to the EKG you see on the right-hand side, which was interpreted as AFib, and at that point, I believe it wasn't RVR yet. Her labs did come back with potassium of 7.4. Her kidney function was increased, so she was an acute kidney injury. Her glucose came back as 815, and she was a little acidotic at 7.16, with evidence of an elevated anion gap of 18, and her lactate was 10. So in further discussion about her presenting history, she had stated that she's had 20 episodes of vomiting in the last 24 hours and 10 episodes of diarrhea that were probably related to her hyperglycemia, further putting her into dehydration, acute kidney injury, and mild DKA. After she was shifted, given IV fluids, she developed a wide swath of abnormal EKGs, anywhere from VTAC, non-sustained, to atrial fib and atrial flutter. She was treated for her she was initially not treated for her VTAC. She was treated for her AFib with metoprolol. Then she developed VTAC, so she was given amiodarone, but unfortunately her QTC prolonged significantly, and it wasn't controlling her AFib adequately, so she was switched to diltiazem. She was admitted to the hospital with acute kidney injury, and that her kidney function didn't normalize but improved throughout her hospital course with IV fluids. Her potassium normalized after shifting, and that she ended up being cardioverted for her AFib and aflutter. There was concern that she had a Mallory-Weiss tear due to her past history of Mallory-Weiss tears, and that she had some blood-tinged sputum. So they treated her with a proton pump inhibitor. She had elevated liver enzymes, which they think was secondary to shock from her bradycardia, and she was discharged without incident by hospital day 4. So we talk, I noticed, or I've looked at our case reviews previously, and we've talked a fair about hyperkalemia, but I think that we see it, or I see it in case reviews just in general because of the use of succinylcholine in patients that are concerning for possible hyperkalemia, but also in these cases where our EKG could be pointing towards hyperkalemia. So I'm bringing it up again. So again, it's considered hyperkalemia if the potassium levels are greater than 5.5 milliequivalents per liter. Mild is considered 5.5 to 6, and moderate 6.1 to 7, and severe is greater than 7. Again, her potassium was 7.5, and she, we oftentimes think about hyperkalemia when we see renal failure patients, especially ones that haven't been dialyzed or have missed dialysis. But there are other reasons for us to consider hyperkalemia. In this so the pathophysiology is that as the potassium increases to life-threatening quantities, it affects the muscles, not just the skeletal, but also the heart muscles. So these patients may not just have arrhythmias, but they may be complaining of muscle weakness or muscle paralysis. This patient, when she presented to the emergency room, had said that she was generalized weak and she couldn't lift her arms off of the bed. So that might kind of cue you in with these muscle complaints if you're thinking that you're seeing signs of hyperkalemia. So the risk factors for developing hyperkalemia is oftentimes you look at your patient's medications, and then you would be looking at, with this diagram on the right, kind of showing you where it would affect the renal system. So potassium sparing diuretics like ACE inhibitors or angiotensin receptor blockers. Are they taking ibuprofen or some other NSAID? The beta blockers, such as atenolol, metoprolol, and labetalol, have been known to be associated with increased potassium levels, as well as meds that we might administer, such as succinylcholine, and then digoxin can also lead to hyperkalemia. Other instances where you would be thinking about hyperkalemia besides renal failure would be, is it exercise induced? Is there rhabdo or crush syndrome, such as a cellular injury? Is there impaired renal function? And in some of our metabolic acidosis cases, like DKA. And then other considerations. And the other considerations I wanted to talk about, which I think I put it on the other side, so I apologize there, is that it's about chronicity. Does this patient live at a higher level of potassium concentration in general? And, you're thinking about your renal failure patients and how not only is it chronic for them, but how fast have they developed this condition, where that will give you an idea of the EKG changes you might see and also how profound their response is to their hyperkalemia. Diagnosis is largely in the emergency setting based off of EKGs confirmed by potassium, unless they're more mild. In that, if you have a wide and slow EKG and you think that there's a possibility for there to be an electrolyte abnormality, strongly consider that hyperkalemia is playing effect here, in that one of the agents that we can give in the pre-hospital setting that temporizes, doesn't necessarily shift, but helps to prevent any kind of cardiac arrhythmia instability or worsening instability, would be calcium. And if your patient is suspected to be hyperkalemic and you end up needing to RSI them, we do not want to use succinylcholine in these patients. Again, a couple of pictures of the EKG changes that you would expect to see. The second one showing peak T waves, the third one showing peak T waves and widening of the QRS, and then further widening to the point where you're looking at a sinusoidal EKG until it gets to asystole or it's treated. So for Clark County protocols, I pulled up bradycardia, and other than getting a 12 lead, you're considering signs of poor perfusion. If there's signs of poor perfusion associated with the bradycardia, consideration could be with atropine and if no response, consider use of an epi drip, placement on GFib pads in consideration of transcutaneous pacemaking for this patient might also, or for a patient that's bradycardic and symptomatic, may also be indicated. In this particular instance, I would say that this patient was, in regards to her bradycardia, stable. She was recorded to have rates in the 20s and 30s, but normal blood pressures. And besides her mildly reduced alertness with a GCS of 14, I believe that you wouldn't necessarily need to go down the route of treating her with atropine, and that if your overall big picture suggested that you thought hyperkalemia was an issue, which was one of the things that you can see in her 12 lead, is that her QRSs continue to widen. So she was 0.20 in this EKG, but also in her first EKG, she was 0.16. So you're seeing this patient widen out while you're taking care of them, and that would help build your case, even with a 30-minute patient contact time, to treat her for at least calcium, if not a trial of shifting. Any thoughts or questions? All right. Moving on to case 3. Case 3 was of a 44-year-old male found in a bathroom. I believe it was Lifeline. He was found unconscious. PPE usage was appropriate for the situation. He was unresponsive to painful stimuli. His airway was open, but he was not protecting. He did have a pulse present, and there was no signs of active bleeding. Vital signs obtained were at 3 minutes after patient contact, noted to be tachycardic at 135, hypertensive at 231 over 133, with a respiratory rate of 9 and a GCS of 3. His room air sat was 96%, and that his past medical history, which was obtained from staff at Lifeline, was that he was a diabetic. He had a history of alcohol abuse and was currently being treated for alcohol dependence at their facility. Staff stated that they'd seen him an hour prior, and they had heard him vomiting coming out of the restroom, and when they went to check on him later, he was found face down with vomit around him. Upon initial assessment, they noted that his pupils were pinpoint. They trialed intranasal Narcan at 2 milligrams without a change. He had a blood glucose of 576, and an IV was established at 10 minutes. His temperature was borderline for fever at 99.9. A 12 lead EKG was obtained, which was interpreted as sinus off of EMS documentation. Repeat set of vital signs at 16 minutes has showed an improvement in his tachycardia with a continued hypertension at 208 over 119. His GCS remained 3. His end-tidal was added to his SpO2 monitoring, which was 100 on room air and end-tidal 41, and that they left the scene at 18 minutes, headed towards the hospital as a stroke alert. They noted at that point that his pupils were no longer symmetric, with the left greater than right, and they obtained another set of vital signs that showed basically stable, no longer tachycardic, but still quite hypertensive, with a GCS of 3. And he arrived at the hospital at 32 minutes. Where I think we did well in the pre-hospital setting is that we got a blood glucose. We attempted, or at least documented, that we were unable to perform a BFAST or a LAMS. Serial vital signs were obtained, as well as serial pupillary assessments. We documented last known normal, and we did not have a prolonged scene time, and the appropriate hospital was notified, as well as the appropriate destination. Where we could improve is that with a patient of GCS of 3 without anticipated improvement and no reversible findings identified, that the prognosis is pretty poor, unlikely to improve, and that he is not protecting his airway. Upon arrival to the hospital, he continued to have a GCS of 3. They noted he was posturing, that his pupil was blown, and at that point he was identified as hypoxic with a SAT of 85%. He was RSI'd and sent to a CT scanner where he had a pretty devastating intracranial hemorrhage involving his pons and midbrain with associated mass effect. He started on nicardipine drip. Neurosurgery was consulted, and they said that this was non-survivable. He was admitted to the hospital. His family was contacted, told of the situation at hand, and they made him comfort measures, for which he had passed away within the first hospital day stay. So I think that it's a good reminder to talk about why we RSI. What's the reason to RSI? What are the indications, and what are the cons of RSIing a patient? So for those of us that have been in any form of healthcare, but specifically emergency medicine, it hasn't always been an option for RSI, both in the emergency room, but also more recently with the pre-hospital setting. So this is a great tool that we have access to, and in some states, it's even more blocked by the state for pre-hospital use. So RSI allows us to produce immediate muscular relaxation and unresponsiveness that improves our odds of being successful with intubation, and it includes pre-oxygenation. These are for patients that are not ideal. They haven't been fasting since midnight, and that there are emergency airways. When we decide to consider somebody for RSI, we always, in the pre-hospital or in the hospital setting, we weigh the pros and cons of making this decision. And the ones that I have listed here are all the reasons, pros, to pursue RSI. So some of these are without, having to, they're kind of pretty obvious. So inability to protect their airway, but they have a patent airway. So a decreased level of consciousness is indication. A patient that cannot oxygenate or they're hypoxic. A patient that cannot ventilate or they're hypoventilating. If you think there's an impending obstruction, so this might be a little gray in the pre-hospital setting, but I think it's definitely something to strongly consider, even if in the pre-hospital setting. So these are patients that have trauma to their neck and expanding hematomas, or these are patients that you're pulling out of a fire and they have evidence of airway burns where there's soot, or you can see that there's swelling already developing on your external exam, or there's stridor on exam. And then expectations of rapid deterioration. Here's a patient that we presented that was unresponsive, hypertensive, with evolving pupillary changes, and then by the time of arrival to the hospital, now is posturing. Cons would be you can't ventilate them. So if you take away if you paralyze them, you can't oxygenate them, you can't ventilate them. They don't have the option for intubation, such as like a malignancy or like a obstruction, like a food bolus obstruction. So just paralyzing them and sedating them, but not getting access to their trachea is going to be an issue. And I think those are, from the top of my head, those are your biggest cons. In addition to consideration, is it just being elective? So our protocols say that the indications for us, without doubt, is airway control and protection, or inability to oxygenate or ventilate this patient. Any questions or thoughts you guys want to talk about with case 3? All right. Case 4 is a 66-year-old male who was found in his car. He had a dispatch was for shortness of breath. It's a little bit unusual, at least in the documentation, that only one crew of the 3 had HEPA mask, gloves, and eye, where the other ones did not document eye. I'm not sure if that was just a fluke. Primary survey is that the patient's awake, his airway is open, but he's labored, his pulse is present, and there's no evidence of any active bleeding. The first set of vital signs obtained were at 16 minutes after patient contact. Heart rate of 97, blood pressure 157/87, respiratory rate of 30, GCS of 15, and SATs of 98%. This one's a little bit unclear. I believe he was on room air, but in the hospital course information, he's supposed to be on oxygen, so he may have been on his home oxygen. And then his end-tidal CO2 is 44. The history that he provided EMS is that he has a history of COPD, and he had reported that he was waiting at the hospital for 7 hours and that they never took care of him, and they left an IV in him, and he demonstrated it by pointing to his arm. He said that he presented to the emergency room for shortness of breath, but left for home because nothing was happening, and he got worse on his drive home. He took 30 puffs of his own inhaler. I did find his presentation where he presented to the emergency room at Peace Health, but although he reported that he sat there for 7 hours, he sat there for 2 hours, had reported to them that he was short of breath for 3 years, that his legs were swollen since a couple days, and he was also there for a psychiatric evaluation. In the triage vital signs that he presented with was a heart rate of 106, same almost blood pressure, 157/90, in that at that time he was on his home O2 requirements at 3 liters at 97%. They had drawn some blood work in EKG, which all were normal for any of the clinicians on the call right now. So he had left. He couldn't find him after 2 hours of waiting in triage. So EMS assessment is that his breath sounds were absent. They placed him on a non-rebreather mask, gave him 5 milligrams of albuterol and 0.5 of Atrovent. His SATs were documented as 100, and that his breath sounds now have improved from absent to diminished with a repeat SpO2 and end-tidal CO2. They noted that he had full sentence dyspnea and that he became agitated with the care that he received and didn't want to be transported. They contacted online medical control at 21 minutes because they felt that this patient was still sick, and although he met the criteria for ability to refuse care, that they felt like strongly this was against medical advice, which was appropriate. This patient I had spoke to on the phone, he was still tachypnic and just talking to him. He appeared to have capacity, which was corroborated by the EMS crews on scene, that they felt that he had capacity to refuse, that he understood the gravity of the situation and the risks of not going. He just wanted to go back to his house, and he was very consistent with his plans or his desires to go back to his own place. So the online medical control refusal was obtained. They appeared to give him actually, I believe what happened at that point was that they had tried to convince him one more time, and then they took him off of the oxygen and the neb. And at that point, he felt like he was not going to fare well. He agreed to be transported, and in the documentation, he had stated that he wanted to live at least just one more week. And I guess that's how severe his impending sense of doom felt for him. They started him back on the breathing treatments. They started a line. They gave him Salumedrol, and they started transport at 42 minutes, emergent to the closest hospital. They noted that he was speaking incoherently and that he was inappropriately laughing, and that his blood glucose was checked, which was normal. His breath sounds were still diminished. His end-tidal CO2 was rising on subsequent vital sign checks, as well as when they checked him again at 4 minutes from his previous set of vital signs, he remained pretty stable in that regards, is that his heart rate is 98, his blood pressure was 182/66, his respiratory rate is 28, his SATs were 98% on a non-rebreather, and his end-tidal now is 46. He started to deteriorate. They trialed CPAP before he was unresponsive. Once he became unresponsive, they removed him from CPAP and started to bag him in which is how he presented to the hospital, was unresponsive and now bagging. And I took a couple of the end-tidal CO2 continuous waveforms. The 3 of them that you see on the left-hand side are from initial contact, midway through the call, and then right before arrival to the hospital. All of them dictate that he's hypoventilating, and he's also not breathing adequately. He's bradypneic, where you should be seeing much more frequent waveforms and normal waveform morphology. The other thing I wanted to point out was that, you know, when you have an obstructive process, you're going to see more of that shark fin appearance. So where they're retaining and they can't get rid of the end-tidal or the CO2 that they have. So this crew was really diligent on staying on scene and getting the patient to agree, ultimately even trying to get online medical control to help facilitate that. And I don't have a lot of feedback to change any of their processes. At the hospital, he was intubated. He became hypotensive, requiring pressors and a central line placement. His blood gas showed that he was retaining CO2 with a PCO2 of 101. He was acidotic. He was admitted to the hospital and discharged on hospital day 2 with a diagnosis of acute on chronic respiratory failure with hypoxia and hypercapnia, and he was sent home with prednisone and a Z-Pak. Since this occurred in early August, he has had 3 more presentations to local hospitals, 2 of which have required admission and 1 of which he was intubated. So he has been seen in the hospitals in our area 4 times this month. So a brief kind of review of documentation and refusals. People want the ability to be autonomous, and that's the right to make informed medical decisions about their health care or their treatment. And we are constantly talking about needing capacity to be able to identify a patient as appropriate for informed consent and informed refusals. And reminder is that capacity is the person's ability to process information and make informed decisions about that information in regards to their medical care. Capacity has 4 components, being 1 is understanding about their medical situation and their decisions after understanding their medical condition, so the risks and benefits of their decisions. 2 is that it needs to be a clear, consistent choice with the patient that they are choosing one way or the other. It shouldn't be that they're constantly changing their mind, drastically changing between the 2 extremes. 3 is that they not only, so they appreciate what you're telling them, but not only can they repeat back what you're telling them, but they understand that it's present in themselves. So that would be like telling a patient that they're having a heart attack and that they can tell you that you were telling me I'm having a heart attack, but they're saying that they aren't having a heart attack. It's just that they're repeating back what you were telling them. And then the reasoning is their ability to understand the situation and the consequences of their decision making. Getting a full set of vital signs whenever possible. Now with our current situation of hostile patients or violent patients, that may not always be possible. If you think that the patient is making, if you strongly feel like their patient is making against medical advice refusal, you're concerned about that patient, or you have any other questions or concerns, you can always contact online medical control. Making sure that you document as best as your ability a refusal form, and then your documentation is your record of what happened, what you did, and what you were able to assess and inform the patient about. Here's our patient treatment rights. We break it down to, on the left-hand side, what consent means, and then the right to make decisions regarding care. If the patient is conscious and rational and refuses treatment, you should document a refusal. If the patient is irrational, refuses treatment, you should contact medical control or potentially a mental health provider. if the patient's family, patient's physician, or nursing home refuses treatment, there are protocols that help guide us on how we should be handling those situations, in that the rational patient has the right to select a hospital to which he or she is transported to in a non-urgent situation. Considerations when the patient's a minor and when you aren't for sure, recognizing again that medical control is an option. The picture on the right-hand side is breaking it further down to no medical need, minor medical need, and immediate medical need. I'm not going to read these to you guys, and we basically talked about immediate medical care is necessary or deemed necessary, and the appropriate handling of that situation, which was done in this situation. The patient was by himself, but a reminder that you can try to persuade patients to make the right decision or make what you believe is the right decision by convincing those people that are important to them, if that's their significant other, their neighbors, their friends, or their family, to get them on board to try to be more persuasive in getting the patient to make a decision that would likely benefit them. And then again, this is something that I feel like we are all aware of, but a reminder is that recognizing or asking the patient why they are refusing care in the first place. It may surprise you why they are resisting treatment or transport, and that if you ask them why would they not want to do this, or why are they hesitant, they might tell you that they have an animal at home, someone they're taking care of, they have legal bills, they don't have insurance, or that might be something that you can help in decreasing their anxiety or stress, or help them problem solve that situation and get them to be able to make a decision that's right for them. I believe that's all I have on those cases. So in summary, recognition of BTAC and the reasons that would increase the odds of that patient being in BTAC, patients that are in older, experienced portions of their life, being respectful to all that are on the call, and with previous cardiac history and or risk factors, things that are slow and wide, really consider if there's an electrolyte abnormality. If you strongly suspect it, go ahead and treat it, or if you suspect it and you are not necessarily seeing widening of the QRS, then you can always consider at least administering calcium chloride or calcium gluconate. Indications for RSI, it's not always that they are hypoxic, but it might be because they are no longer protecting their airway. And that is not going to change in the foreseeable future. And then recognizing that patients have the right to refuse, but if you believe that there's a strong chance that they are going to rapidly deteriorate before picking up and leaving, maybe having them no longer having the treatment that you're providing, or asking them to get up and to walk into another portion of their room and potentially causing their reoccurrence of the presenting symptoms, to persuade them that leaving them at this point is not a good decision. Here's a couple of the sources that I referenced. And do you guys have any questions?
I just have one comment on the last case. Yeah. And I agree with everything you said, and the crew did a really nice job of handling that. Just for context, the healthcare system is under historic amounts of stress right now. June was one of our busiest months in history, and that was before we had this last surge of COVID. Now we've had this surge of COVID, and we have as many inpatients now as we did during the peak in the winter. Legacy has canceled elective surgeries for 2 weeks starting yesterday. And so both hospitals have systems in place where, like this patient, they're going to be seen by a provider, they may get tests ordered. But we're also seeing a lot of people who leave without being seen because really, only the patients that are needing immediate care are getting brought straight back. So just unfortunately, you may be seeing more cases like this where people were seen and then left. So I just want to provide that as context for the work that you're doing in the field.
That's a good point. Yeah. And I'm sure it's similar at Salmon Creek. We try to see them by one of our PAs, see them when they check in and start to work them up based off of their chief complaint. So it's not uncommon for them to have labs already obtained or imaging done or even an IV placed like this patient had while they're waiting in triage. Well, I thank you guys for your attention and your questions from our MPDs. If you guys have any questions or concerns, please feel free to email myself or the MPD's office. And thank you for doing what you're doing out there.
Thanks, Dr. Gadwell. Very nice.
Thank you.
Yep. Concur. Very great cases. Thanks.
Mm-hmm.